So now there are two types of scores which are called hematoma expansion scores. In fact, I am telling you three scores, and one is a brain score, another one BAT score, depending on whatever signs I have shown you earlier. Am I audible? The screen is visible? Hello? 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 Are you,
Started.
you are able to sing?
No, it's started. Screen.
The screen is visible now,
It is starting, sir, but not yet. No, sir, not yet.
but I don't know what is the reason. I really can't understand. Is your signal okay? Others are saying. So the brain score is 85% probability of hematoma expansion is dependent on the ICH volume, and you get this is about 24% point score, and you get a recurrent ICH if it is there, then 4, anticoagulation with warfarin onset 6, intraventricular extension is 2, numbers of hours to baseline computed. So all these things will make us realize that the hematoma expansion can be assessed, and there is another Browers et al. Score also. So these are available in the literature. We can, so now whether we do CT angiography, do we have to do DSA? That's the main question. So whenever we suspect macrovascular, so if the acute CT angiogram is negative, and the confluent white matter hyperintensity lacunar infarctions are seen, history of hypertension is present, the predicted yield of macrovascular cause is less than 1.8%. So there is no requirement of DSA here. If history of hypertension is not there, then there will be 6% yield of macrovascular cause. So even though there are lacunar infarctions, you can still do. That means this is all intermediate yield group of, but if acute CT angiogram is positive, then there is a high yield of DSA. So you'll have to do a DSA also. So whether to do DSA after CTI is settled. You have to do DSA to establish this. So now how we go about it is whether CT angiography is positive or if CT angiography is negative. And depending on that, whether hypertension is there or hypertension is not there, these are the two things which will help us. The goals of treatment are supportive and specific. And see, the recommendations in 2015 for emergency diagnosis and assessment tells us that a baseline severity score should be performed as a part of the initial evaluation of the patients with ICH. And so we'll learn ICH score, and rapid neuroimaging with CT or MRI is to distinguish ischemic stroke from ICH. It has to be done. CT angiography and contrast enhanced CT may be considered to help identify patients at risk for hematoma expansion. So a vascular imaging is also important. The time is brain concept is applied now to ICH also. That because the first 6 months, first 6 hours, the hematoma expansion takes place. So what do you, the checklist for the first hour, what will you do? Complete blood count with platelet count, PT, PTT, INR. You have to rule out all the causes for hemorrhage, and head imaging results, hematoma size, location, presence of intraventricular hemorrhage or not, and you have to assess the Glasgow coma scale and calculate ICH score, which I am going to show you, and coagulopathy reversal. If INR is less than 1.4, you have to bring it down to less than 1.4, and blood pressure has to be lowered and kept between 140 to 180, and surgical hematoma evacuation, airway and ventilation management. So these are the immediate checklists which you have to keep in mind. We'll go by ICH score. We usually do ICH score in all our cases, and there are 5 key components, and their score ranges from 0 to 6. The Glasgow coma scale 3 to 4, 5 to 12, 13 to 15, and accordingly ICH volume more than 30, less than 30. We have already discussed how to calculate the ICH volume, and if there is intraventricular hemorrhage or no, and infratentorial origin of ICH, whether it is present or not, age more than 80 or less than 80. So based on this, you can say 30-day mortality at if the 5 points are there 100% and 1 point is 13%. So you can prognosticate and counsel the relations accordingly when you receive a assessment. What is specific treatments? The treatments are for raised intracranial pressure containing the size of the hematoma and removal of hematoma. The first we have already mentioned about NovoSeven and factor 5 7A. After phase 2 trial, the whole India started using this drug, and but when phase 3 trial came, and there will be more there were more thromboembolic complications, thrombosis and cardiac complications. So the drug was abandoned for ICH use nowadays. But one important thing is stroke unit care, and meta-analysis of 13 RCTs involving about 3,570 patients said a stroke unit care reduces death or dependency, and you can look at the confidence interval 0.47 to 0.92. So here close cardiac and neurological monitoring can be done, oxygen can be administered, antipyretics, methods to reduce aspiration, early nutrition, glucose control, blood glucose. So effective medical and nursing care. The stroke unit has really helped in making the patients recover fast. The management of perihematomal edema and increased ICP after IVH. The therapeutic targets are what we want is we want to keep the cerebral perfusion pressure, which is between 50 to 70, and ICP should be less than 20. That means mean arterial pressure minus intracranial pressure is the cerebral perfusion pressure. So elevate the head, sedation and analgesia, hypertonic saline or mannitol, neuromuscular blockade, hyperventilation, and hypothermia, endovascular 35 degrees centigrade for 10 days also has been tried. So ICP monitoring is required if GCS is less than 8 and clinical evidence of transcendental herniation and intravitreal the hemorrhage and hydrocephalus. So one thing is that mannitol, this said that you should use if you are able to monitor ICP, and extracorporeal or extraventricular drainage of CSF, craniotomy, ventriculostomy. So there are various studies have done who have been quoted in literature, and the osmotherapy, mannitol bolus is 0.25 to zero point 0.5 grams per kg IV over 30 minutes, 4 to 6 times per day. Maintain normovolemia and serum osmolality and less than 310 to 320 milliosmoles per kg, and it's better to not cross this and monitor osmolality. Furosemide may be added at an initial dose of 1 milligram per kg intravenously. It's always better to add furosemide with mannitol. If you give 3% saline, it is more effective, and it maintains you maintain the sodium between 145 to 155 as an infusion. If you want to use a bolus type, it has to be 23% or 7% sodium chloride. So systolic blood pressure, earlier recommendations were less than 180, diastolic one less than 105, mean arterial pressure about 130. These were earlier, but now the after the trials of attach 2 and interact 2, interact 1 and 2, attach 1 and 2 have really changed our perception of the management, because hypertension is supposed to expand the hematoma. So that's why it has become very crucial for us to understand. So hematoma enlargement is seen, and the if the blood pressure is controlled, the hematoma enlargement is less. So the cerebral circulation, the autoregulation, what we were thinking earlier, the chronic hypertensives have a curve which is shifted to the left. Normotensives have a different curve, the cerebral autoregulation. So I'm sorry, and I will go back. Yeah, yeah. Yeah. So patients with cerebral ischemia lose their ability to auto-regulate. That's a myth. So there is a increasing risk of ischemia if you bring down the blood pressure. That was the concept. But some PET scan studies subsequently has shown that this concept is questioned now. So people have become very wise, and PET studies of 5 to 22 hours after ICH showed no evidence of ischemic penumbra, perihematoma, cerebral blood flow reduced, but also reduced the oxygen extraction fraction also. PET studies showing no significant reductions of perihematoma cerebral blood flow after moderate reductions of mean arterial pressure within 6 to 24 hours. So what happens is this has given rise to uh, new studies, and those new studies are the interact 2 study, which is the second intensive blood pressure reduction in acute cerebral hemorrhage trial, which results are out in 2013. And this has shown that you can reduce the blood pressure of systolic blood pressure less than 140, and it compared with a standard guideline of less than 180, and the BP target is maintained for 7 days, and they looked at the MRS at 90 days. And so this is the ultra early definite time of onset within 6 hours. Systolic blood pressure should be above 150 to 220, no indication of contraindication. This is the inclusion criteria of the Interact 2 trial, and 2794 patients, and the odds ratio, you see, just it is just it is saying that the both the outcomes are equal, but it is safe with slightly good outcome. The odds ratio is about 0.87. So intensive lowering of blood pressure less than 140 millimeters of mercury in less than 1 hour within 6 hours of onset of symptoms, and has to be maintained for 7 days, or and studied compared with guideline based target of less than 180. And the MRS and ordinal scale showed safe with good outcome. So people have started, and hematoma growth was observed, and it was reduced. So ultra early BP lowering has come into vogue. And so the conclusion is intensive BP treatment started within 6 hours of hematoma onset can modestly improve functional outcomes, can improve quality of life in survivors, is constantly safe, does not affect mortality, does not significantly reduce hematoma expansion. So, with these things in mind, there will be the second trial that has come is attached to trial. That has confused again. The attached to trial is the NIH funded phase 3 RCT of early intensive blood pressure reduction in ICH with nicardipine infusion, started within 4.5 hours and maintained for about 24 hours. At least one systolic blood pressure more than 180 before randomization, and systolic blood pressure less than 140 and versus less than 180. So that means which is recommended. And the main endpoint they checked is MRS at 90 degrees, and enrollment was stopped at 1000 patients because of the futility of the because there is no change. So interact 2, you see mean blood systolic blood pressure within first hour, intensive 150, standard 164 they have attained in this in their study. Whereas in attached 2, the intensive 129 and standard 141. These are the different early BP profiles. So attached to conclusion is intensive blood pressure reduction targeting systolic blood pressure less than 140 millimeters of mercury early after ICH does not improve outcomes. Moreover, there are more renal complications in patients treated with a more aggressive BP target. That has again put a stop to our thinking. But the guidelines have come. Guidelines of 2005, AHA guidelines, ICH patients presenting with systolic blood pressure between 150 and 220 and without contraindication to acute BP treatment, lowering of systolic blood pressure to 140 millimeters of mercury is safe and can be effective for improving functional outcome. Class 2A evidence, level of evidence is B, and it is revised from previous guidelines. For ICH patients presenting with SBP more than 220 millimeters of mercury, it may be reasonable to consider aggressive reduction of BP with a continuous intravenous infusion and frequent BP monitoring. So this recommendation has really revolutionized our treatment schedules. So now the labetalol can be used 5 to 10 milligrams every 15 minutes or 2 milligrams per minute continuous infusion. Esmolol 250 micrograms per kg loading dose and 25 to 300 milligrams per kg per minute maintenance dose. Nicardipine is 5 to 15 milligrams, which is used in attached to trial. Hydrologen 5 to 20, and nitroprusside zero point 1 to 10 micrograms. So the guidelines say that you should within 6 hours of onset treat systolic blood pressure if it is more than 150 and up to 220, and lower it acutely to 140 millimeters of mercury and keep it there for 7 days. That's the important aspect. So these are the guidelines, and based on patient's comorbidities and level of chronic hypertension, the target should be, if you have doubt, in 140 by 180, and keep it that. See that the blood pressure is maintained for 7 days. Okay, so that's the conclusion about blood pressure and ICH. I'll give some more final thoughts. Uh, Ideal target of blood pressure reduction in acute ICH remains unclear. Intensive BP reduction appears safe. Gradual and sustained reduction likely is better. Less than 130 diastolic blood pressure may be unsafe. So systolic blood pressure less than 180, no proof that further reduction decreases the risk of hematoma reduction. So still we are foggy in our thinking. But one thing is that we would try and keep the systolic blood pressure between 140 to 180 range. So the secondary prevention of recurrence, and so once you started treatment and progress trial has shown that perindopril plus indapamide, what is marketed as Coversil plus, is recommended there for adults who had suffered an ICH. Does subsequent blood pressure lowering therapy compared with standard care improve outcome? Yes. So we always now treat all these patients with perindopril with indapamide based on. So what is the role of surgery? Cerebellar hematomas, there is no doubt. More than 3 centimeters, lobar hematomas more than 10 centimeters in a worsening patient. Putamen hemorrhage not known. There's stitch 1, stitch 2 trials have been done, and subgroup analysis also has been done. The stitch 1 is an RCT, hematoma evacuation within 24 hours of randomization, 113 patients. Stitch 2 RCT hematoma evacuation within 12 hours, 601 patients. Early surgery is not superior to medical treatment. Odds ratio is 0.86. You can see the confidence interval crossing 1.62 to 1.20 with a p-value of 0.37. So meta-analysis of stitch 2 with 14 other RCTs has shown some indication that early surgery is superior in select cases where GCS is 9 to 12, less than 8 hours, and volume more than 30 ml within 1 centimeter of cortical surface. So there is a role for surgery and very close to cortical surface. If the volume is more than 30 ml, you can evacuate, and that's one. So second option is decompressive hemicraniectomy, whether I can do. So the earlier one is a case series of 12 patients. The volume should be more than 60 ml. 11 patients survived, 6 had a good functional outcome. That is MRS 5. That means almost all they are bedridden. Case series 2, 23 patients with predominant hematoma. 13 patients had good outcome, 10 had a poor outcome. So these results are encouraging. So what they did was, now they started a Swiss trial of decompressive craniectomy versus best medical treatment of spontaneous supratentorial intracerebral hemorrhage, a randomized controlled trial which is in progress. So we cannot give any recommendation about decompressive hemicraniectomy in ICH. So minimally invasive surgery with the stereotactic aspiration and thrombolysis has been studied. Phase 2 FAST trial and MISTI 2 trial. FAST is about 28 patients, and MIS-BTT is 64 patients. MISTI 2 is 118 patients. Reduction in hematoma volume, reduction in edema, no overall difference in clinical outcome. That is very disappointing. What they did is stereotactic aspiration, and I put Actylis inside the hematoma. So now the MISTI 3 also has appeared, and MISTI 3 is an open label blinded endpoint phase 3 trial at 78 hospitals in USA and Canada, Europe, Australia and Asia, and the results are very disappointing. Meaning there is no difference in the outcome, but the procedure is safe. That's what MISTI 3 trial has shown us, and there is no difference in the outcome between the functional outcome at 90 at 1 year. The other thing is life-saving procedures and external ventricular drainage to reduce ICP and herniation. And occlusions are problem, infection is a problem, communicating hydrocephalus is a problem. So whenever you do external ventricular drainage, we are faced with so many problems. Ventriculostomy alone or ventriculostomy plus thrombolysis is the study for intraventricular hemorrhage, and this is a study, and clear IVH trial is that Early and effective clearance of blood from ventricles is recommended. Maintains EVD functional, avoids permanent VP shunt, improves clinical outcome and reduces mortality. Secondary hemorrhage and infection are complications which can occur. The short-term improvement outcome at 30 90 days, but not at 12 months. So there is intraventricular hemorrhage, a different approach. You have to put a EVD and put an altiplase. So the clear IVH trial done 52 patients with IVH open label phase 2 trial, endoscopic surgical evacuation, lumbar drainage. After that, what happens is they have done a clear 3 trial, and clear 3 trial also did not show any improvement, any difference between the, it's an RCT, between the two treatment groups, but it proved that it is safe. So maybe more number of cases have to be done. So surgery recommendations: surgical treatment of ICH, stitch and stitch 2, no difference in long-term mortality or functional outcome. Evidence to support cerebellar ICH more than 3 centimeters in diameter or with brainstem compression or hydrocephalus may benefit from evacuation. The current AHA-ICH guidelines recommend patients with cerebellar hematoma deteriorating neurologically or with brainstem compression undergo surgical evacuation as soon as possible. Initial treatment of these patients with ventricular drainage alone rather than surgical evacuation is not recommended. EVD should be considered if concerns for hydrocephalus communicating or not, especially with intraventricular hemorrhage, or to facilitate in management of elevated ICPs is recommended. Fiber optic intraparenchymal ICP monitors can also be considered in these cases. So early medical management, new things are coming. There is a hemostasis and the IDEF trial presented in the Stoke conference in 2019, multi-center double-blind placebo-controlled study to evaluate deferoxamine mesylate or deferoxamine, an iron chelator, because we discussed in the pathophysiology the role of iron. Daily infusions into 3 days of 32 milligrams per kg per day of desferoxamine did not improve recovery and neurological function at 3 months, but potential outcome benefits were seen at. So there are other drugs which are tried based on this minocycline, fingolimod, dexamethasone. So more and more studies are being done to prevent the secondary injury of ICH. And the supportive management, airway management, cardiac arrhythmias, glucose, fluid and electrolyte balance, DVT prophylaxis, temperature control, seizure control and prevention, blood pressure management, which we have already discussed. So fever is one of the important things. You have to keep the body temperature low, and acetaminophen treatment is recommended if it is 37 degrees or what. So there is a benefit. So keep the temperature down is a recommendation. Blood sugar attached trial. A decrease in serum glucose concentration leads to a reduction in the hematoma expansion and improved outcome. So the blood sugar should be less than 140 milligrams per dl for the first 72 hours, and so this has been studied repeatedly. And AEDs, another important things for the neurosurgeons are very fond of recommending the AEDs. And for adults with ICH, do prophylactic anti-epileptic drugs reduce the occurrence of seizures or epilepsy or improve outcome? But initially there was no RCT, but subsequently another trial which I'm going to show you, they said there is no recommendation as a prophylactic medication, no role for prophylaxis. If seizures occur, you treat them. And now they said phenytoin is not a good drug, and the favorite drug nowadays is levetiracetam, which has got so the recommendations of American Heart Association say clinical seizure should be treated with anti-epileptic drugs, preferably levetiracetam. Continuous EEG monitoring is probably indicated in ICH because non-convulsive status may happen, because many depressed mental status patients may have non-convulsive status. Patients with a change in mental status who are found to have electrographic seizure on EEG should be treated with anti-epileptic drugs. But prophylactic anticonvulsant medication should not be used. So this should be kept in mind. There is no role for prophylactic levetiracetam. See, the levetiracetam also has some problem with cognition, and cognitive function is supposed to have got affected in the in this so levetiracetam. So it is better not to use without any indication. If you have indication, definitely use that, because there are certain side effects which are seen. So This is the final recommendation. There is a whether the early seizure versus late seizure. What is the recommendation? In 113 ICH patients in Switzerland, 11% had a seizure within the first week. Early seizure was not associated with mortality. Early seizure was associated with late seizures. So they developed something called a cave score. 1 point for lobar hematoma, age less than 65 years, volume more than 10 ml, seizure within a week, they require anti-epileptic medication. So we have some type of description when we can start, and depending on the cave score, and this score is dependent on lobar hematoma. Okay, so that's another interesting thing that we learned today. The current guidelines, if you look at that, though the class 1 evidence is clinical seizure should be treated with AEDs. Prophylactic anti-seizure medication is not recommended by American Heart Association, which we can repeatedly say. So there will be oral anticoagulation reversal. Again, this is a problem, and there is no clear-cut guideline. Though the guidelines say that coagulation factor deficiencies, you have to replenish the factors. ICH with increased INR, discontinue warfarin treatment, vitamin K 5 to 10 milligrams IV, which normalizes INR in 24 hours. FFP 10 to 50 units per kg acts within few hours. Prothrombin complex concentrates are the favorites nowadays. They act within few minutes, 10 to 50 units per kg, and factor 7A acts within few minutes, normalizes INR, but it's not real. Platelet transfusions are used only if there is platelet related bleeds, and that is thrombocytopenia related bleeds, and not otherwise. Nowadays, iduricimab and nexafol for the direct thrombin inhibitors, and 10 factor 10A inhibitors. So they are also now have got different type of agents which are very costly. The main point is resumption of anticoagulation, because in cases of patients who are on antiplatelets and warfarin, if they develop ICH, when are you going to resume? The risk of recurrent hemorrhage versus thromboembolism has to be assessed. Older age, more than 65, ongoing anticoagulation, greater number of microbleeds on MR, they are the risk factors for recurrent hemorrhage. In lower ICH with the non-valvular atrial fibrillation, recurrence of ICH is more, so anticoagulants are to be avoided and antiplatelets are used instead. These are all only experienced recommendations. There is no evidence. Non-lobular ICH, resume anticoagulation. So that's a clear indication. So crucial issues with the conflicting evidence. Retrospective studies, 2,869 patients with atrial fibrillation, heart valves, additional risk factors for stroke, resumption of warfarin 10 to 30 weeks. Systematic review of 492 patients after 72 hours, 120 patients with mechanical valves resume after 2 weeks. So what is the guideline? Guideline says resume after 7 to 10 days. European Stroke Initiative resume after 10 to 14 days. So if it's dabigatran, and that's a different story. So now we can have a guideline about 7 to 14 days time. Depending on the patient's requirement, you choose. There is no actual study, but they tried doing a randomized control trial, what is called the restart trial. So you can summary of recommendations for reversal of antithrombotic agents. You can say that the vitamin K antagonists and direct factor 10A inhibitors and direct thrombin inhibitors, that is dabigatran reversal, and unfractionated heparin, low-mer heparin. How do you do that? So what we usually want is nowadays to use prothrombin complex concentrates in cases of a bleed, which rapidly reverses the bleeding problem. Okay, right. So I'll go on to second. So this is a restart. This is a randomized. That's what I was telling. If antiplatelet associated, now the chaps who are on antiplatelets, they develop ICH. Whether to start antiplatelets or not is a big question. We don't know the real answer. We don't know. We don't know really. Despite this, these results of restart trial exclude all but a very moderate increase in the risk of recurrent intracerebral hemorrhage if you restart antiplatelets. But their median time of restart is almost 80 days. So after 80 days, almost 3 months, they started antiplatelets again. But people have started within 7 days, within 1 week also. What maximum number of patients in this trial, they have started after 90 days. So we really don't know. So there are so many ongoing trials of this. There are so many ongoing trials. Restart France, StatTich, Apache, AF, NASPAC, ICH, SOSTART, A3 ICH, Aspire. So many antiplatelet trials are awaited. So we really don't know what is to be told to the patient. But right now the evidence says that safely you can start after 2 months and antiplatelets. That's what is about antiplatelets. Okay, so DVT prophylaxis, intermittent pneumatic compressions plus elastic stockings, low dose low molecular heparin or unfractional heparin 1 to 4 days from the onset of ICH. You can use filters are useful when anticoagulation is contraindicated or on acute proximal DVTs. Surgical embolectomy after 7 to 10 days if there is a requirement of that. So DVT prophylaxis and treatment of symptomatic DVT or PE has been assessed evidence wise and recommended. Patients with ICH should have intermittent pneumatic compressions for prevention of venous thromboembolism beginning the day of hospital admission. That's class 1 evidence A. And second was gradual after documentation of cessation of bleeding, low dose subcutaneous low mer heparin or unfractionated heparin may be considered for prevention of venous thromboembolism in patients with lack of mobility after 1 to 4 days. So this 1 to 4 days is a good guideline for us. We can start. Okay, so that's the systemic anticoagulation or IVC filter placement is probably indicated in ICH patients with symptomatic DVT or PE, and the decision between these two options should be taken into account several factors including time from hemorrhage onset, hematoma stability, etc. But what we follow usually is these restart on the 1 to 4 days afterwards. So and this is the long-term mortality. What I am showing is that there is no change. Whatever we stand, we learned about ICH, and since so many years, there is no long-term mortality improvement in ICH cases, which is about 20 to 30% in India, and the long-term mortality has not improved, whether it's cerebellum, deep cerebellar, lobar, or brainstem. So still we have to learn a lot about this. So adverse prognostic factors: age, ICH volume, growth, and see the GCS score at low GCS, intraventricular blood, and infratentorial side. These are all factors covered in ICH score. So annual risk of recurrence of ICH, which is very low for hypertension, 2%. AVMs, it is 18%, and sacral aneurysms or medium-sized artery aneurysms, 50% the first 6 months. Cavernous hemangiomas 4.5%, venous angiomas about 0.15%. So there is an annual risk of recurrent ICH. Accordingly, you can plan your interventions. Prevention of recurrence of ICH, and you have to use long-term anticoagulation with warfarin as a treatment for non-valvular fibrillation is probably recommended after warfarin associated spontaneous low pulses because of the relatively high risk of recurrence. Only there we have tend to use, but when stratifying how a patient's risk for recurrent ICH may affect management decisions, it is reasonable to consider the following risk factors for ICH recurrence: lobar location, older age, presence and number of microbleeds on gradient echo MRI, ongoing anticoagulation, presence of apolipoprotein E, epsilon 2 or epsilon 4 alleles. So in these cases, we have to be very careful to restart because they are likely to be. The optimal timing to resume oral anticoagulation after anticoagulant related is uncertain. Avoidance of oral anticoagulation for at least 4 weeks in patients without mechanical valves might decrease the risk of ICH recurrence. This is one guideline which we have to. The aspirin monotherapy can probably be restarted in the days after ICH, although the optimal timing is uncertain, as I showed you in restart trial. The usefulness of dabigatran, rivaroxaban, apixaban in patients with AF and past ICH to decrease the risk of recurrence is uncertain. We don't know. Maybe we can start after 3 months. So the ICH care pathway involves initial diagnostics, hyperacute and acute treatments, CT angiography, MRI. Again, I am saying that again time is brain in ICH also. Stroke units are care is more important. Blood pressure management, anticoagulation, reversal in macrovascular things, and where there is INR is more than 1.7. EVD, consider pressure monitoring, consider surgery, minimally invasive and decompression, and of course the supportive care of continued BP monitoring and control, and secondary injury targets which we have discussed, and fingolimod and desferoxamine, dexamethasone, whether they are going to help or not, future time will tell us. MRI for accurate diagnosis and prognosis is important. The secondary prevention, blood pressure therapy, optimization of medications, and blood pressure with Coversil plus, that is perindopril plus indapamide, functional neurorehabilitation, and these are the timelines which you can see in the bottom. 21 20 days management is required actively for the ICH cases. So the all patients should be monitored in an intensive care unit, and if patient's GCS is below 8, he has to be intubated and put on mechanical ventilation. Okay, if there is clinical improvement within 14 days, you can extubate, or you have to do tracheostomy in these patients. And other cases which we have already said, long-term anticonvulsant should be considered. There are further seizures more than 2 weeks after the onset. Immediate seizures do also say that they may have late seizure, but late seizures are likely to recur more often. So you have to start on anti-epileptic drugs, which we have already discussed. What are the factors where we choose? Patients with hydrocephalus should receive an intraventricular catheter, and this catheter you can keep for 3 days, and beyond 3 days usually infection will bother us, so we will not use that. Patients with a mean arterial pressure of more than 130 millimeters of mercury should receive intravenous antihypertensive treatment, and cerebral perfusion pressure should be maintained around 70, and the drug which would like to use is nicardipine infusion, but it is better to have an IV drug than oral medications for it. So emergency neurology life services pathway, the first is when you get a case of ICH, adequate airway, and that to be non-contrast CT, and if there is ICH, brief medical and medicine history, BP control, hemostasis. If INR is should be less than 1.4, and you have to use reversals, and consider surgery, consider external ventricular drainage. If raised ICP is there and GC is less than 9, and you keep ICP less than 22 and cerebral perfusion pressure more than 60, so you require ICP monitoring here, and you characterize ICH and ICH score, volume, location, and plan to communicate transfer to another ICU if you don't have facilities. So this is the emergency care pathway that is recommended for ICH cases. So conclusions, all ICH patients need supportive treatment. There is insufficient evidence to justify a general policy of early surgery in patients with ICH. It has to be tailored to the needs of the patient. Patients with cerebellar and lobar hematomas less than 1 centimeter from cortical surface might benefit from craniotomy. Endoscopic surgical procedures may be beneficial in deep ICH with selected patients. The results of ultra early hemostatic therapy is promising, but can be tried in selected patients. Supportive treatment, acute low auricular blood pressure, management of fever, blood glucose, bleeding after oral anticoagulation, oral coagulants, reversal and resumption, DVT prophylaxis. These are things which we discussed. So the guidelines, which are the references which we have used for this preparation of the lecture, is given here. So still, ladies and gentlemen, it's very foggy. Let us wait for more studies, and we don't know really what is the correct line of management. But whatever is taught to us by the seniors with experience, we are following. There is little evidence, but till we get some evidence, we follow the same guidelines which are given in the preceding slides. Thank you very much. If there are any questions which we can discuss, you can ask. Okay. So I think we'll end. Let's you